I should find out if you can hear me. If you could hear me during that whole process, just feel free to put that in the chat forum. Let me know that you heard me there. So Psoas, the Psoas is your friend. Thanks again for joining this webinar. And oh, okay, you heard me. Great, thanks. So thanks again for joining this webinar. And I'm going to take 25-30 minutes to talk about the Psoas. Also going to do a brief demonstration for you. And again, if you have any questions for those of you that are just joining in at the moment, then go ahead and type them through the chat forum, and I'll be sure to get back to you right away on those. So what I wanted to cover is how to palpate the Psoas, when to work the Psoas, and where to work the Psoas. And as far as how to palpate the Psoas, I'm going to show you a link to a YouTube video that I have on palpating the Psoas. It's out there for you. I will show you the link at the end of this video, so you can go to it at any point and you can look at how I actually palpated the Psoas. But one thing I want to talk about is palpating the Psoas using directional resistance. And some of you who have already heard about directional resistance and have seen my demonstrations on it know what I'm talking about. But what I mean is being able to sink into the tissue to the point where you feel end range, and then from there you can feel for which way the tissue, the myofascial tissue, is going, what direction it's resistant, and then working in the direction of resistance. So if, for example, if this was the Psoas, I can sink in to the actual area of the Psoas and then feel for directional resistance, either superiorly or inferiorly, and then going in the direction of resistance. But not only are we going superior and inferior, but we also want to go medial to lateral or lateral to medial, depending on what may be happening with our client. Now, obviously, this is not an area that we go to during a regular 6-minute spa massage. This is usually the area that we go to if someone has some sort of lower back issue. So keep that in mind. If you're going to work with a client and they have some sort of lower back issue, first thing you want to do is verify any type of diagnosis that they might have. And if they don't have a diagnosis, then my advice is to encourage some sort of diagnosis. I have a client that I worked with her for about 3 to 4 months, and she came in full-on diagnosis, full-on MRI with a report of findings. And I absolutely suggest that if they have gotten an MRI, that you get a copy of the report of findings so you know what is going on where. Once I had that information, then I had a really good idea of what may be going on with the soft tissue. And then that led me to being able to work specifically with that soft tissue and help her to the point where she was symptom-free, no more symptoms. She was actually dealing with some sciatica pain, and she was dealing with some numbness and tingling of her foot, her right foot in her case. And once I knew that, and once I knew what was going on with the possible discs, then I could then tailor my work on the psoas to help her get that psoas to relax more and to not pull on that vertebral disc. So speaking of vertebral disc, I want to mention bring up one slide for you. Just want to share one slide, and give me 1 second here while I find it. And there we go. So you may have seen this picture before. It's a picture of the psoas major and minor. But one thing I want to bring up that doesn't normally come up with, yes, for that person who's confirming, this is being recorded and you'll be able to watch it later. Yes, it will be. So one thing I want to mention that doesn't come up usually in workshops is that the psoas tissue is attached to the vertebral body, but there are sections of that psoas tissue that are directly attached to the intervertebral disc. So I'm going to say that one more time. psoas tissue, whether it be tendinous, connective tissue, is attached to the vertebral body, and it is affecting the vertebral body. But there's also psoas tissue. Some people will say that it's muscle tissue. Some people say that it's connective tissue. I think that it may depend on the actual client, and I may not know until we can actually go in there and do a dissection on a cadaver. But some of that psoas tissue is directly attached to the intervertebral disc. So once that starts to happen, if we have some sort of pulling on that psoas tissue on the intervertebral disc, now we've got issues going on, pain issues, compromising of some sort of nerve root, that type of thing. But what that also means is that we can actually directly affect the person's spinal column and any possible spinal column issues that are related to the intervertebral disc by working that psoas. All right, I'm going to get rid of this slide. So keep that in mind when you're working the psoas. Now, when do you work psoas? That's another question. The way that I've been trained, we usually wait, and we usually don't get to the psoas right away. We kind of work our way into the psoas, and I'll do a little bit of this in the demonstration. But my suggestion is that you work firstly with rectus abdominis, that you make sure that rectus abdominis now has the capacity to allow you to sink in past that abdominal wall. You may actually have to also work omentum, and you may actually have to work mesentery tissue in order to allow you to sink easily through the small intestines into psoas territory. Now, imagine if you don't do that. Imagine if you don't actually work through that abdominal wall and you get directly to psoas. So you may actually affect the client positively by working the psoas, but all the other abdominal tissue interior to the psoas will not have the capacity to take on that work. And then what you're left with is a supple psoas, but everything else, that its superficial shell is now, what's the word, not resilient. And then you're stuck with the psoas tightening up possibly and not being able to take on the full extent of your work. So long story short, you really have to build up to working the psoas. And in my training, it's like one of the last things we do. And yes, it can absolutely affect the back. And people will say, well, why don't you get to it right away if you know that it's going to affect low back issues? Well, you can't get it right away because you have to build up and you make sure that that whole abdominal area has what we call the adaptive capacity to take on the work. So the next point of the psoas webinar is where exactly to work the psoas. And a lot of trainings get to psoas work around where the iliacus is. And I won't bring up the slide again, but if anyone really wants to see anatomically iliacus and psoas, just let me know. I'll pull it up. Just go ahead and type in that you want to see the slide again. But a lot of training hangs out in psoas iliacus area. And that's great. That's a great place to work. But think about where a lot of people are coming to you, where a lot of people have pain, and people that are coming to you may have pain in just particular areas. And it's in general, I'm speaking generally here, most people are coming to us with issues in L4, L5 area. And if you're going to deal with psoas with respect to addressing those issues, then you really need to get to the L4, L5 area. And I actually think that most of that is actually in L4. The reason I say this is because when you get to L5, you can affect L5 vertebrae by working sacrum. And that's a whole other subject, being able to work sacrum, being able to assess the sacrum and work it. So I think that getting to sacrum will affect L5, but getting to L4 via the psoas is a great way to do so. And what we end up doing then is we end up actually working a little higher up. A great way to measure where the L4 is you measure the top of the iliac crest, and when you go right to the middle, so let's say this is iliac crest, when you go right to the middle, that is L4 vertebrae. And that's where you want to go in and palpate. A lot of cases, that's where you'll find psoas that may be tightened, and that may be torquing the vertebrae or actually pulling on an intervertebral disc. The other thing is, when you work the psoas, I highly suggest that you really take your time to palpate, because when we've got psoas issues, in a lot of cases we have unilateral tightness or shortness slash weakness. So one psoas may be contributing to the actual issue, and that particular psoas may have particular directional resistance, and you may actually work that differently than the other psoas. The other psoas may be actually reacting to psoas number one, and it may be also compensating for psoas number one, and it may have a different directional resistance. So keep that in mind. It's usually unilateral, and usually you won't work both psoas the same. Alrighty. So one more thing before we go on to the demo, and I've got this little handy dandy. Let's imagine this is a vertebra, and we're going to turn it this way, and we've got spinous process and transverse process on either side. I'll move it this way. So spinous and transverse process, and it's at an angle so you can see it. So this represents the client facing this way, so anterior, and this is their back. If we have a tight psoas, it's possible for the unilateral tightness to actually torque a vertebrae in such a way, or it may actually jam one vertebrae onto the other, making the facets stuck. So there may be some stuckness in the facet from the inferior facet of this vertebrae and the superior facet of the one below it. So in this case, if we've got shortness of one psoas in here, then we may have a possible rotation this way. And if you're following the Morales method and how we describe vertebral rotation, this is counterclockwise rotation along the vertical axis from a superior view. So the inverse is also possible. If we have unilateral shortness this way, then we have a clockwise rotation of the vertebra. And in this case, it's possible that the directional resistance kind of goes from lateral to medial. So we have possibly this spiraling happening that is pulling that vertebra in this way. So keep that in mind. When we have the person in supine position, it's very easy to kind of go in here and start going in different directions and trying to also just sometimes just put direct compression onto that psoas tissue. Keep in mind that you may not actually, in a lot of folks, you may not actually sink directly onto the psoas tissue. You may be affecting tissue above it. And my suggestion is, when you've got folks that it's a little more difficult to sink into the psoas tissue, my suggestion is to go at an oblique angle. And again, I will copy a link to the YouTube video of palpating the psoas so you can get to that. But remember, going into at an oblique angle is the best, and getting it to that line of rectus abdominis is your best bet to sinking in. That way you don't have to get right on top of rectus abdominis and to now, fight through another layer of abdominal tissue. So let's get to a demo. Like I said, that YouTube video that I'm going to link to shows psoas work, but it shows it in supine position. So what I thought I'd do is do it a little differently and show you a technique that we show in the Relieving Low Back Pain workshop, which is working the psoas in sitting position. Now, sitting position is not the easiest position sometimes for a client to receive. Sometimes it can be a little intense. So make sure you've got that line of communication open with your client. And A, they're comfortable with the work that you're doing, and B, they are comfortable letting you know when it's not comfortable. And I think that's it. Let's get to the demo. Again, if anyone has any questions, feel free to type away. All right, so I'm going to reposition the laptop, so give me a few seconds to do that. And thank you, Elena, for being a model today. Let's do this here. There we go. A little closer. There we go. And the other thing, one more thing I wanted to mention is when you're working with clients, my suggestion when you start to work with Psoas, and especially working with Psoas in sit position, tell them to bring a pair of shorts and a sports bra so that they're comfortable moving around. If you're working in the spa world, then this might be something that you work on after the session. Maybe save a minute, 2 minutes after the session and say, hey, I want to try this. Can you redress and work with you in this position? I used to work in the spa world for 6-7 years, and I was pretty notorious for saving a couple of minutes after the end of the session and doing a couple of things that not only helped the client, but also helped me to stand out and help me get a repeat request. So not that I did that for that reason, but it was really a nice byproduct of getting them on the table while they're dressed and doing a couple of extra things afterwards. So the first thing I want to mention is we've got the rectus abdominis here, the 6-pack, and at this angle is where I really want to get to. I really want to be able to work right through here this way, so I'm meeting the center where the psoas would be attaching to the spinal column. The other thing I want to mention is, in a lot of cases, a lot of people are told, oh, wherever the belly button is, then that's where you go in. It's L4. That's not the best way to find L4. L4 is really well situated when you look at the top of the iliac crest and you work right in here, in her case, right at belly button. But believe me, you're going to run into someone who is going to have a belly button somewhere else, higher or lower, and then it's not the greatest landmark. So here, let's do some sitting work. And let's do the case where, for example, we have, let's say this is L vertebra, and we have her left psoas, Elena's left psoas, that is tighter and shorter and bringing vertebrae in this position. So this may be happening. It's affecting the intervertebral disc and possibly causing pain. So I'm going to go in this way. So what I end up doing is, I'm going to move my chair just a bit. What I end up doing is sinking in here. And I tell my client, here's probably one of the most difficult things to do, is to tell your client to relax their belly. Everyone is holding in their belly when they're coming in, but I really need it to be relaxed so I can sink into this psoas tissue. And I tell my client, again, let me know if this doesn't feel good, and we can always do something there. So here we go. Let's say it's L4. I use my hands this way to sink into psoas, and my left hand is going to be in here at some level, but it's really the right hand that's going to be doing the work. And I'm not going to sink in all the way in here with her, but just going to mock it up a bit. Actually, take it back. I am kind of sinking in a little bit. Is this okay?
Fine.
Okay. So here I am sinking in, and I'm going this angle, as you tell. And once I reach psoas, I would ask my client to lean in towards me. And once I start leaning in towards me, I start to feel a little bit of that directional resistance of the psoas. And then what I end up doing is I end up tracking it. So let's say the directional resistance was inferior to superior, then I start going in that direction, my hand as it goes this way, as they're leaning forward. Usually this is done, I'm going to turn my back to you just for a second. Usually this is done like so, okay? But in this case, because I want you to see it, oh, thanks for moving. So usually it's done like this, and usually they're at the edge of my table, and I've lowered my stool so I can get out of their way when they start leaning forward. The other thing is, when I have them lean forward, I want them to lean forward straight back. I don't want them to lean forward curled. So if they start leaning forward curled, then I lose the psoas. So what I want is a straight back so I can get to that psoas. Let's do this one more time. Here I am. And let's say I feel that, okay? Okay. Let's say I start to feel psoas, and sure enough, I'm starting to feel her psoas a bit. Again, I'm not going to sing all the way because I haven't really set this up and prepped the work, but here I would ask her, go ahead and lean forward. I usually say, you know, lean forward if you're going to conk me on the head with your head. And as she starts doing that, keep going. As she's doing that, I feel the directional resistance, the DR of the psoas, and it's going inferior to superior. So I start going with my right hand, starting inferior to superior. How's that? Feeling all right? Okay. All right, and bring it back to neutral. If I had a rotation, like this, it's possible that as she leans forward, maybe also going medial to lateral, as I felt directional resistance of that psoas from medial to lateral. You may not be able to tell. I'm going to do it this time. You may not be able to tell in this video because it's really a subtle move. But I really I'm finding myself at kind of a medial point of the psoas, and then asking her to go ahead and lean forward a little bit. And then once she starts leaning forward, then my hand fingers are moving from middle to lateral, almost envisioning that I'm lengthening that psoas and hopefully giving space to any type of intervertebral disc may be going out of place, also helping vertebral body to find its position in neutral. Go ahead and strap. Again, my left hand is not doing a whole heck of a lot except stabilizing in here. And there you have it. So as we're sitting, like I said before, prepping to get to this is important. One of the things that I like to do to prep is to hold this rectus abdominis tissue and then, again, feel for its external resistance as a whole. I like to first start with moving it clockwise and counterclockwise. In her case, I feel resistance in the counterclockwise direction. So I may work that. I'm not going in the direction of the large intestine because I'm not working the large intestine. I'm actually working the rectus abdominis, and I'm feeling its directional resistance in the counterclockwise direction. You can see how easy it is for me to move in the clockwise direction, and counterclockwise, you can feel the resistance. So, you know, this would be one of the things I want to do, prep, or I get into psoas work. I could also move medial to lateral, side to side, and feel for DR this way before I get into deeper work. I mentioned the omentum and I mentioned the mesentery. The omentum is a layer, is this adipose tissue layer more anterior by the abdominal wall, and the mesentery is actually this tissue that's this connective tissue that attaches the small intestine to the anterior part of the back. So sometimes that can be tight in some folks. Thanks, Elena. So there you have it, folks. If you have any questions, feel free to ask. Thanks again for sitting in. Oh, there's a question here. How can you know or palpate for a vertebral tilt? Thank you. Great question. One of the things that we do, especially in the relieving low back pain class, we check for rotation. So rotation can happen, and we check for that on when the person is prone. So we actually check using the spinous process as a gauge. So if we're running our fingers along spinous process and we feel that there's a spinous process more to the left than to the right, then it's possible that the vertebrae has a rotation. Now, I'm going to tell you a secret. Rotation is a product of movement along sagittal plane and coronal plane. So when we have rotation, we also have movement along the sagittal plane and along the coronal plane. And when that happens, there's also movement of the facets. So a vertebrae that is rotated this way can also have, and when you say tilt, you might be meaning rotation, but there's also tilt, flexion, and tilt and extension, and that is movement along that sagittal plane. So when we have rotation, we also have possible tilt. So that could be then, or that could indicate stuckness in facets. That gets a little more complicated. I usually bring that up in the Relieving Low Back Pain 2 class if we have time. You know, that gets into like the really juicy intricacies of working with actual working with a vertebrae. So I start, to answer your question, I start with palpating the spinous process, and then from there, trying to extrapolate what might be happening with the facets superior and the facets inferior, and then creating a strategy from there, and then from there we reassess. So hope that answers your question. Any more questions, feel free to ask now, or you can contact me via Facebook at the Morales Method, or via email, Marty@MartyMorales. Thanks again for joining this webinar. I really appreciate it. I look forward to seeing you in other webinars or in future workshops. All right, and I will include the link to the YouTube video right now as I end this webinar. All right, folks, have a great evening.